Hello, hi everyone. The topic of today's presentation is post-denture insertion. And in the last topic, we had covered the denture insertion and what all steps to be followed during denture insertion. So next step is the recall appointment or the review appointment, during which we check the effects of the denture and does the patient have any specific complaints or any issues, or there are any problems with the denture that can be corrected at this appointment, so that the patient can be more compliant towards wearing a complete. So the learning objectives are: you should be able to differentiate the errors caused by the occlusion and the errors in the denture basal seat area. You should also be able to summarize the various post-denture insertion problems that happen and how to manage them. So basically, post-insertion treatment is a phase of the complete denture procedure that includes the treatment and patient education. You not only treat the patient for any specific complaint, but you also educate the patient as to how to manage day-to-day activities with the dentures and what all shortcomings are there and how much time it will take to get accustomed to wearing a complete denture. Because as we know, this is a continuous learning process and a learning curve for the patient in order to function better and have a good quality of life with processes such as a complete denture. So periodic recall and checkup is important. So for denture post denture insertion, you need regular basic examination instruments. You need articulating paper, disclosing denture disclosing paste, that is pressure indicating spots. And if you don't have articulating paper, you may also use bite wax. So first recall is usually done 24 to 48 hours after delivering or the after insertion of the complete dentures. This is a critical period for dental wearer because during this period he has worn the denture and he may have certain specific problems that or adjust, or you may call it as an adjustment phase, that need to be addressed at this time. The operator should remove the dentures and examine the tissues, especially the denture basal seat areas, or to see if there are any pressure spots, sore spots, any ulceration that may need to be taken care of. So you also observe the occlusion, whether the occlusion is proper, is there any slide in centric or any gaps in the occlusion, or there may be the occlusion on the right side is more heavier than the occlusion on the left side. This may result in trauma to the basal seat tissues under the dentures. Patient may also have a cheek bite or the tongue bite problem, which also need to be checked seldomly. Now, post-denture insertion phase, the problems may be associated with, as I told, with the occlusal surfaces. The either patient may have a heavy bite on one side or traumatic bite on one side, or the patient may have a bite because of which he is unable to chew soft food or small food particles such as rice and barley and such because of the poor occlusal contact. Problem may also arise from the denture impression surface or the tissue surface of the denture. There may be resin tags or any sharp edges that may be causing impingement on the soft tissue or the mucous membrane and may also cause ulceration. Also, problem associated with the polished surface of the denture, like if the polished surface is too thick, that is the palatal vault in an upper denture, it may result in difficulty in pronouncing certain syllables or alphabets. So these also need to be addressed at this time. So basically, problems that frequently you may encounter is patient may complain of discrete painful ulcers. These painful ulcers may usually be seen at the denture peripheries or the near the relieving structures such as the buccal and the labial frenums. The flanges may be sharp or they may be putting pressure, so they may need to be relieved. They may need to be shortened and rounded. Pain while insertion and removal of the denture. This is generally due to tight fit of the denture and because of the undercut, especially in the maxillary anterior region and the mandibular posterior lingual region. So you may need to provide some additional relief by trimming the tissue surface of the denture. There may be pressure. This may be due to either to denture overextensions or to the increased vertical dimension. And there may be impinging of the tissues, especially loose areolar tissue in the buccal vestibule or in the alveolingual sulcus. So again, these extensions and need to be checked and adjusted. Patient may have difficulty in swallowing. This may either be due to overextended posterior parietal C, that is the post-diam area, and also seldomly difficulty in swallowing may also be due to the overextended lingual flanges in the retromylohyoid area. And sometimes it is also due to the increased vertical dimension. In increased vertical dimension, in that case, you may have to redo the denture to reduce the vertical dimension. So we locate with the finger, we apply pressure on the sometimes on the soft tissues, we palpate the soft tissues and ask the patient whether he has pain, because sometimes he may not be able to accurately pinpoint where the pain may be. So, and then we identify the cause in the denture, and it is generally due to overextensions of the or the pressure spots on the denture bearing area, which need to be trimmed and polished. One thing, as I mentioned previously, the denture trying appointment, we can use a denture pressure indicating paste or the disclosing paste that when we applied on the tissue surface of the denture and placed in the patient's mouth, so that we can accurately pinpoint which areas of the denture base are applying pressure and they can be relieved. Sometimes, if the issue of increased vertical dimensions, such as there may be soreness of the ridges and there may be difficulty in swallowing, that if it is mild, then it can be corrected by selectively grinding the occlusal surfaces of the denture, and this may sometimes solve the problem. Otherwise, we need to repeat the jaw relationship. That is, we may need to remove the teeth from one of the dentures and then use the denture as a record base and add wax rim to it, and again repeat the jaw relationship, specifically vertical. So this is the pressure indicating base, and this is how is it applied on the denture, and then it is placed in the patient's mouth. Patient is asked to bite in centric relationship, and then any areas which are exposed, these indicate the pressure indicating areas or that may result in sore spots, and these are trimmed and polished. Then coming to other factors that may result in discomfort, that may be problems relating to the occlusal surface of the denture. That is, patient may have pain on eating, and this may be due to anterior prematurity or the anterior premature contacts and because of lack of balance occlusion. So these prematurity, that is the anterior, there may be increased overbite that may need to be adjusted by adjusting the lower anterior teeth. There may be pain in the lingual anterior region of the lower denture. So this may be, if it is not due to any overextension, they should look for any slide, that is slide from the centric relationship position. So when the patient bites in centric and then slides the mandible forward because of habitually closing the mandible anteriorly because he has been edentulous for a long time, then this needs to be corrected in the denture. This may we may need to repeat the jaw relationship step and repeat the teeth setting. Usually, it will not come to that extent because slide and centric it can usually be observed at the trine and the denture insertion appointment. If there is any pain or inflammation of the labial aspect of the lower ridge, this can be due to increased incisal overjet, which is causing incisal locking. And again, we need to adjust the lower and upper anterior teeth to allow the teeth to slightly have freedom of movement in the anterior region. Pain may also be in the periphery of the denture. Uh, this may be either due to the masseter muscle and may also be due to the posterior temporalis muscle. If during bottom molding the masseteric notch was not properly captured and the denture flanges are overextended and applying pressure in this area, that is in the buccal flange of the lower denture, they or the buccal flange of the upper denture. This may be due to the pressure from the masseter and the temporalis muscle, that is tendon temporalis, and mostly this is because of either, as I mentioned, because of the improper final impression bottom molding, or it can also be due to the vertical dimension, increased vertical dimension. If the patient has cheek or lip biting, it sometimes happens. Likely the functional, this is because the functional width of the sulcus has not been restored. If there is any lip bite, then there is poor lip support, that is there is inadequate horizontal overlap of the anterior teeth, and it may also be due to the decreased vertical dimension, which results in poor muscle support and entrapment of the lip mucosa when the patient chews or when the patient talks. And if there is any tongue bite, then it may be due to the lack of the lingual overjet. This may be because the teeth have been placed more lingual to the lower ridge. Remember, we have a Pound's line which extends from the retromolar pad to the mesial line angle of the canine. So, if the teeth are set too far lingual to the this line, then this may result in the encroachment upon the tongue space and may result in tongue biting. So now coming to the adjustment, if there's problems with the occlusion, this can usually be adjusted by using articulating paper or a white wax and by selectively grinding those areas. In some cases, when there is slide in centric or the increased vertical dimension, then we may need to remove the teeth from either one of the dentures, usually the lower denture because of convenience, and may need to uh, do jaw relationship and reset the teeth and do a trying for the lower denture along with the upper denture. And in some cases, we may need to remove the lower lingual cusps if they are causing tongue biting, that is because of the reduced lingual overjet. Then in some cases we may need to contour and reduce the height of the lower lingual cusps to provide space for the tongue and to prevent the tongue. Now coming to the factors resulting in discomfort relating to the polished surface of the denture. Till now we were talking about problems associated with the occlusion, that is the problem with the denture acrylic teeth, and we talked about problems related to the tissue surface or the impression surface of the denture. Now problem associated with the polished or the cameo surface or outer surface of the denture. There may be pain at the posterior aspect of the upper denture on opening of the jaws. So this may be due to the thick or the overextended buccal flanges, and because we have not provided sufficient space for the coronoid process, and it may be due to impinging of the postdam area on the pterygomandibular raphe. So these areas need to be removed. The pterygomandibular raphe, the postdam area, and that area needs to be trimmed. And if the buccal flanges are too bulky, then they may need to be trimmed and polished to provide space for the coronoid process of the mandible during opening and closing. Again, this has a direct impact from the final or secondary impression when if these areas have not been properly recorded. So next, coming to the aesthetics. Now, apart from the pain, soreness, and the things that we can elicit and observe in the patient, a patient may also have certain problems related to aesthetics. Like patient may not be satisfied because of the mental or emotional response, because a denture suddenly changes the patient's facial appearance, and some patients may not be able to tolerate it, or they may have different aesthetic expectations. So this is directly related to the mental status of the patient. So proper counseling of the patient needs to be done. Patient needs to be more aware of the impact the denture will have on his facial appearance and on his quality of life, and it will take some time to get adjusted to the new look. And some common problems that may be seen are dissatisfaction with the appearance. Maybe the patient is not specifically satisfied with the teeth color. Maybe he wants more whiter teeth than the teeth shade you have given. So it is very important during teeth selection to select the appropriate shade of the teeth and to also confirm this with the patient. Now, patient may also be dissatisfied with the teeth position. Usually, sometimes patient may say that his anterior teeth are too labially paced, or the anterior teeth are very short, that he wants them to be more longer, or or the patient may complain of excessive anterior teeth display during smiling or talking, which he may not like. He has to be made aware of these things. Mostly, counseling is required in these things because this is not an actual problem with the denture, but it is how the patient perceives the denture. So patient has to be made aware that with age, the appearance of the lower anterior teeth becomes more visible, and the upper anterior teeth become less visible due to the loss of tonicity of the lips and cheek, and due to attrition of the upper teeth. So all these things, counseling is very important because aesthetic is mainly directly related to the mental attitude of the patient in most of the cases. Now coming to phonetics, when complete denture is the first one, there is always some temporary alteration in the speech owing to the thickness of the denture, especially the upper parietal vault area where the denture is covering. the hard palate, and so patient will have some difficulty in adjusting to the denture because his speech will be slightly slurred and it will be slow and it is awkward. It takes a couple of weeks to get used to speaking with the new denture, so he has to be made aware of this. So patient should, as I mentioned during the denture insertion appointment, patient should be made to encouraged to talk loudly, read magazines, books, so that he can overcome this problem more rapidly. Now, phonetics in relation to denture is very important in order to correct any speech defect that may occur in the denture wearers, and it is directly related to the accurate design of the complete dentures. That is, the position of the anterior teeth and the thickness of the palatal wall play a major role in how the patient is able to pronounce certain specific words like palatolingual sounds like sh, j, ch. So if a palatal wall is too thick, then the patient may have difficulty in pronouncing church, street, and if the anterior teeth in the denture are set too far labially or too far lingually, this may result in difficulty in pronouncing labiodental sounds such as F, V, and if the increased vertical dimension is there, that is vertical dimension is excessive, then it may result in difficulty in pronouncing bilabial sounds such as B, P, like Papa, Bombay, etc. So these things need to be corrected, and this, if it is like I said, if we know the cause, we can correct the cause either at the same appointment or at a different appointment. So now coming to the recall appointment, the recall appointments is usually is scheduled. First recall is within 24 to 48 hours or 72 hours, depending on the convenience and of the patient. And second report is usually after 1 week, which is very important because most of the denture patients require at least two recall visits in the near vicinity. And the third recall can be kept at a 3 to 4 month appointment to see how the patient is doing with his new corrected dentures and how is his acceptance, and to motivate him. And a regular maintenance recall is done at every 1 year. And after 5 years, we need to make new dentures, or we may need to reline or rebase the dentures if the occlusion is correct and the denture fit and retention is good. So this is generally the program for recall of our complete denture patient, and that brings us to the end of this short and brief presentation.